we talk about the drug crisis in America, we usually picture the hardest moments. An overdose, a 911 call,
Westcom 911, what is the address of your emergency?
an emergency room in the middle of the night.
We're going to be taking her straight to the operating room, OR 9.
But what if we don't just focus on the hardest, most dramatic moment? What if the most important moment happens long before? The second before the first drink, the first vape, the first pill, the juncture at which most teenagers make that life-altering decision. And when we do focus on that turning point, we're now seeing some pretty good news.
In 2024, 42% of high school seniors said that they've never used any addictive substance at all, and 2/3 said that they've not used any substance in the past month.
That quiet shift didn't happen by accident. It's the results of decades of prevention work. And this year, it was named a national priority.
Good morning, and thank you for joining us today as we launch the 2026 National Drug Control Strategy.
Boosting prevention, treatment, and recovery efforts nationwide. The White House saying it wants to create a drug-free America as a social norm.
For the first time, this year's National Drug Control Strategy put primary prevention, keeping drug use from ever starting, back at the center of the national conversation. Today, I'm joined by two people who've spent their careers on opposite ends of that journey and have somehow now ended up in the same place. Dr. Roneet Lev is the Chief Medical Officer for the White House Office of National Drug Control Policy. She's an emergency physician who's treated countless patients and who helped shape the strategy from the inside. And Dr. Carolyn DuPont is a psychiatrist and vice president of the Institute for Behavior and Health. She grew up in a family that has shaped the national conversation around prevention, treatment, and recovery for decades. She spent her life making the case that non-use can be the norm. One started with the individual and moved toward policy. The other started with policy and moved toward the individual. And here's what I love. They don't always agree. They'll happily debate the science right in front of you, but underneath, there is a deep, long-standing friendship. Years of mutual respect between two people who come at this from different perspectives and learn from each other every time they're in the same room. This is Empathy Affect, the Forsmarsh Media podcast that explores the human side of government. I'm Melissa Sosinski, and today we're talking about what it really means to prevent addiction before it starts, why a drug-free life is becoming the norm for a new generation, and how two doctors who see the world differently find common ground in the same hopeful truth. Drs. Lev and DuPont, welcome to Empathy Affect. It's an honor to have you both here today.
Thank you so much for having us.
Yeah, thank you. It's fun. We're going to have a good time.
Absolutely. So both of you have worked directly with patients facing substance use disorders in emergency rooms, clinics, and in communities. What does it feel like now to be working at the level of national policy and prevention strategy? What do you carry with you from those encounters you've had?
Well, first of all, you are the sum of your experiences, as our psychiatrist would tell us, right? So I have not stopped being a doctor. I've been an emergency physician for over 30 years. I think I've treated 120,000 patients, and I take all those experiences with me to my work here. Not just in the hospital, but, I had a podcast and I learned a lot. I was involved in medical politics. Even, being a mom and having a family, you take all those experiences with you, and I'm giving all of that to my job here in government. And I'm finding that all those experiences, help shape, and I think they make me successful in my job, even though I don't have experience in government. Those other experiences are working to push our agenda and priorities forward.
Absolutely. Dr. DuPont?
Yeah, I love this question. Working in primary prevention is the best. I just want to say it is the most exciting work that I do. And I think one of the reasons is because it's not really often in medicine that we have the information we need to really make a difference in people's lives by preventing the initiation of a chronic, lifelong, and potentially fatal disease, the way we do with substance use disorders. And so I feel like as a physician, I see people who are much further along on their journey with difficulties with mental health and with substance use disorders, which often go together. And so having that opportunity to think, wait, what could we do different for future generations of people? That's so exciting. And so I feel so lucky to be working in this. I do want to say that I have a really long-term view on prevention. So a little bit of history for me is that my father was the second White House drug czar, that's what's now ONDCP, and the first director of NIDA, the National Institute on Drug Abuse. And so I literally grew up around the dining room table talking about prevention, treatment, and recovery. And so this is like in my blood. But then when I became a psychiatrist, I kind of, for a while, put all that aside and I really focused on patient care, this patient in front of me. And so when I think about prevention, I always think about that individual. It really, we think about numbers when we're doing big work on strategies and policy. We're thinking about big numbers, communities, the country, but you always have to think about those individuals, the individuals that this is going to affect. And so this is the pleasure of my life to work in this field.
Well, so Caroline, it seems like we have cross paths. So you started thinking about things broad and then went to patient care. And I did the opposite. I was always about the individual and now I'm thinking broad. So it both works.
It both works. And we need all those perspectives at the table.
Absolutely. And speaking of which, we're talking broadly. ONDCP released the 2026 National Drug Control Policy this month when we're talking in May. I'm wondering from both of you, what is the most important shift you see compared to previous strategies? And what does it signal to healthcare providers, prevention practitioners, and communities?
All right, I'll take it from here. And then I can't wait to hear what Dr. DuPont has to say, because she'll be like the critic. But in general, strategies always talk about prevention, treatment, recovery. I think what makes this a strategy different, it's very ambitious, it's robust, it's visionary. We start our strategy with emerging threats. We want to be ahead of the enemy, ahead of the threats, not behind. And we create a vision, and the vision is that we want to be comprehensive in what the threats are, from mortality data, morbidity data, drug seizures, what's on the ground what patients are experiencing. That's how we start. We talk about supply and being fierce, and we could see that in the government being fierce on the issues of supply. And when it comes to issues of demand, we're clearly defining prevention, and I know Dr. DuPont's going to love this, that it's primary prevention, preventing drug use before it starts. Because what's happened in the past, there's primary prevention, secondary prevention, tertiary prevention. Everybody was doing prevention. Everything was prevention, and that really robbed the whole focus of primary prevention. So we make that very clear that we want to bring primary prevention back into focus, and bringing prevention science and evaluation. Not just everybody does prevention, everybody has a program, but bringing the science and outcomes to that. And when it's treatment, we also have, very visionary treatment. We want to make treatment easier than getting drugs. We want to bring addiction to the mainstream of healthcare. And then we want to go upstream. We don't want to wait to my experiences in the emergency department where people are in the worst of disease. Think about treating the precancerous lesion rather than trying to get chemotherapy for stage 4 cancer. Think about treating prediabetes instead of being on an insulin pump forever. So that's kind of our vision with treatment. We always want to be there for everyone. We believe in rescue. Second, not just second chances, but third, fourth, fifth, 10th chances. You always have to be there. Sadly, because of the threats of fentanyl and even worse, opioids, we need to strategically place naloxone. We need to have it in the right places. And then we also, as always, want to promote and celebrate recovery. There's 25 million Americans living in recovery. They're showing the example. We actually need to learn and study them because it's not one size fits all. I think that's where research be how are you successful? And we're very excited about it.
Yeah, I mean, it's definitely holistic, covers the whole life cycle from primary prevention, as you were saying, through recovery, the supply, the demand. I want to turn to Dr. DuPont. Prevention, as Dr. Lev was mentioning, is really near and dear to your heart. So, from your perspective as a prevention practitioner and someone who's connected to local coalitions across the country, where does the strategy meet communities where they actually are?
This is so important. So most prevention is local, it's small, it's one community at a time. And it's so important for them to have the information and the support from policy at all levels of government. And so then this national strategy's emphasis on primary prevention is a really big deal to bolster the work of coalitions who are already there, boots on the ground, doing the work. Also, the support of the Drug Free Communities DFC program is essential. And so I want to just say that the people who are doing the work, they know how to best serve the people in their own communities. But having this shared vision of normalizing non-use for youth and recognizing that's in the best interest of public health, this is a public health message, and that's, again, supported from the very top, is really important because this work is hard. Like Dr. Lev said, primary prevention often gets kind of shoved to the side and kind of looked down on. People don't necessarily recognize how critical it is as a public health strategy. And so really highlighting it. So I love that whole spectrum. We often have our kind of colorful rainbow spectrum where we show that kind of universal prevention messaging on this side, and it goes all the way through selected and indicated and treatment and recovery. All of those things are so important, and everybody needs to be at the table.
Yeah, I mean, no surprise. I mean, Dr. DuPont and her father were both mentors to me, so that definitely has an influence. But it's interesting, Carolyn, in the strategy, we explain the different population cohorts in order to understand what people need, right? So we have the cohort of people who don't use drugs, they've never used drugs. That cohort needs messaging, good job, continue. Most people are just like you. Then we have a cohort of people who misuse. They don't have a substance use disorder. They're making risky life choices and they need education. That's a different messaging. And then we have the people who have a substance use disorder, from mild to severe, and they deserve compassion and treatment. And then we have the people in recovery. So, different cohorts require different messaging and resources. And I think when I see this infighting that you were talking about, I take them back to the cohorts.
Hmm. That makes a lot of sense too. I mean, we've seen, say, in like the tobacco space, different kinds of messaging for like vaping prevention with young people versus more like combustible tobacco, cessation for older folks. The messaging really needs to be, targeted to the audience that makes sense. So definitely resonating there. Another thing about the strategy is that it makes creating a drug-free America as a social norm, as a central pillar. That framing is pretty bold in my mind. So why does norming matter so much to behavior change? And what does it actually take to shift a culture around drugs, not just a message?
So, Melissa, I don't think that messaging is bold. I think the data shows that that's where we are right now. What we did is usually say, oh, we want to teach kids not to use drugs and don't do this. All we did, instead of saying all these kids are using drugs, all we did is switch it from a negative to a positive. That's all we did. So we're now highlighting not all the people who are using drugs, we're highlighting that 83% of people don't use drugs. That's just the data. So we are, and instead of, saying, what we see on TV or what we hear, or even if our profession, it seems like, drugs are all around us. The fact is most Americans are not using drugs. So we want to push that social norm and expand it. And what I've learned from the professionals in prevention science is that pushing the social norm is what moves. Everybody, there's peer pressure. If we emphasize the fact that most people don't use drugs, we want to be healthy, in order to achieve our life's dreams, whether, it's athletics or music or writing or whatever, or family. In order to be your best, you do that better by being drug-free. And that's why the majority of Americans make that choice. And we want to expand upon that.
So I want to clarify a few things with this that I think are really important. And one of the things is, what do you mean when you say drug-free? And I love that term, drug-free. So I'm very in support of it. I have a little bracelet that says drug-free. I love it. But you have to make sure that everybody's talking about the same thing. So one of the things is, I talk about primary prevention. I'm talking about youth. I'm talking about people under the age of 21. And that correlates with the law, but it also correlates with brain development. And for youth, when we're talking about drug-free, we're talking about all the drugs that superstimulate the brain's reward system. Alcohol, nicotine, cannabis, and all illicit drugs are in that umbrella. And so I want to make sure that we're being really clear about that. And I love your data, and I absolutely agree that we don't have to create a social norm. There already is a social norm that's ready to be recognized. So we at the Institute for Behavior and Health looked at the Monitoring the Future, which is the big data that our nation collects to follow young people and their drug use. And it's usually used to look at what percentage of high school seniors are using X, Y, or Z drug or whatever. But we did research where we looked at that data in a different way. And we said, what percentage of high school seniors have not used any drugs, no alcohol, nicotine, marijuana, or any other drug? And we did it both by lifetime and by past month. And what we've seen is over the past 50 years, we have data from 50 years because, in fact, that second White House drug czar, who I again mentioned is my father, Robert DuPont, he started that Monitoring the Future with the University of Michigan. So anyway, back in the 70s and 80s, it was something like 3 to 5% of high school seniors had not used any substance in their lifetime. So 95 to 97% of high school seniors had used something. And now that number is over 35% of high school seniors have never used anything in their lifetime. And that's a huge change that's been going on for 50 years. And the reason it's been happening is because of prevention. Prevention really works. The messaging really works. But the more important one to consider is past month non-use, because I never want to think about this as a purity test. This has to do with a health standard, like other health standards, like did you wear your seatbelt or not? When you get more information, you can change your behavior. You can start wearing your seatbelt. You can start wearing your bike helmet. You can stop using substances. So that past month non-use used to be like the 16 to 20% of high school seniors haven't used in the past month. Now it's over 60%. Over 60% of high school seniors haven't used in the past month. That's really different than what most adults think. And that's because it was different 30, 40 years ago when those adults were in school. And so they think that's normal, that like it's normal for kids to use. But actually, the normal is non-use. And I think that's really important. I also want to say that the American Academy of Pediatrics came out with a wonderfully strong statement. They said the non-use message should be reinforced by pediatricians through clear and consistent information presented to patients, parents, and other family members. And so we are not alone in promoting this non-use message. And so having it again appear in the strategy and with such strong language and supporting this change that's already there is really wonderful.
Yeah. So Carol, I like your more precise, and you mentioned all the great data that your dad started, and I agree with almost everything you said.
You said I was going to be the contrarian. Look who's going to be the contrarian.
See, what we're using the age of 25. You said 21, and I think.
Oh, I love 25, Roneet. I am so with you on 25.
What I tell people is age 18 and 21 is for lawyers, but I'm a doctor, okay? And so as a doctor, the age is 25. I'm not going to compromise on the medicine and the science of when the brain grows for your politics and for your laws. So, if you want to use, 18 is legal to do a lot and 21 is legal to do all sorts of things, but it's not a healthy choice. So we have that 25 in our strategy. We're using 25 across government together. We're on that. So I'm giving you permission, Carolyn, to move your 21 to
I
25.
mean, I love 25. And when I talk about brain development, I always talk about that. And actually, I think it's moving older than that. And here's the actual secret. These substances aren't safe for anybody at any brain age.
No
I mean,
kidding. Yeah.
that is really true. But what I have found when we're talking about prevention is it can be really helpful to talk about young people because you get much better traction. Then we get a lot of pushback from adults when you talk about everybody. So I'm always prepared to do that. And the reality is that people put off initiating use of any of those substances that hijack the brain's reward system until after the age of 21 or 25, they're very unlikely to start them. And so that's one of the things that it's not like where I have a gate there that I'm like, now it's a free for all, use anything you want. No, what we see is that in terms of behavior, that risk taking that's part of that adolescent period and part of that brain development part, that's the part we need to protect from that early exposure to substance use. And you're absolutely right. And that goes back to that point that I made at the beginning that not initiating use wildly decreases the risk of that chronic, lifelong, and potentially fatal illness of substance use disorder. But I also want to talk about the connection between mental health, other things, anxiety, depression, psychosis. All of these things can be made worse or more likely by adolescent substance use. And that is something that when I'm talking to youth, they're very open to that discussion because they're really concerned about their mental health. Young people today are more aware of mental health than I feel like any generation in the past. And so when I show them that data of the relationship between substance use and worsening mental health, the light bulb goes off and they're like, wow, I don't want to do that. That makes a lot of sense.
I'm so glad you brought in mental health, and that is proudly in the strategy as well. It appears several times, even in our emerging threats chapter. We talk about all the psychiatric boarding in the emergency departments. I couldn't help myself as an emergency department, but a big percentage that we have not researched is because of substance use. And that correlation of substance use disorder, mental health disorder, that's there. And studying that, I think from the emergency department is really important because then we can make smarter drug policies and smarter resources, because we always argue, oh, and we need more mental health beds, or we need more long-term beds, or we need detoxes. It's like, well, why don't we study that population and make educated, policy and resource choices? And the other place mental health shows up is in the treatment substance use disorder. If you take everyone who has a substance use disorder, half of them have a mental health disorder. If we separate that, you're missing half the population. It doesn't make sense to separate that. We need to handle that both together. And the other place it shows up is we really want to put a focus on early onset psychosis. And we see that kind of, again, I can't help my emergency physician analogy, but like a heart attack. You're having chest pain, you're having EKG changes, we get you the cath lab, we open up, door to balloon time is critical. And it's critical because if you don't act upon it, you're going to have permanent damage to your heart. And the same thing is with your brain. If you have early onset psychosis, first time psychosis, if you don't do anything about it, you keep using drugs, then you will have permanent damage to your brain and have schizophrenia. We are creating in America more and more schizophrenia, bipolar disorder than needs to be because of drugs. And several drugs could do that, but out of all the drugs, the one with the highest conversion rate from one episode of psychosis to permanent mental illness is cannabis, is marijuana. So we want to reverse that.
If you take one thing away from this, that is the most important thing, that what Dr. Lev just said. That is so key. It's something that's happening right now, and it's going to have a huge negative effect on our individuals, our families, and our communities and our country for decades down the road if we don't do something about that. One of the things I was going to bring in with that commercialization is there are a lot of people that are, again, trying to make money off of our young people. And one of the things that means is that the drugs are different, they're stronger, there are different delivery methods, there are different packaging, there are different techniques of hooking people. And so our young people, I have that good news, I was saying, that really good news about the norm and how many people are making that active choice not to use. But the people who are using are at much higher risk because the substances are so different than what they were in the past. And if we don't pay attention to that, and if we are too substance specific, then we're going to miss that there's a whole new threat that maybe we don't even know about today. And so really arming people with this concept of non-use for health is vital.
And the analogy you made, about your heart health, about, tackling prediabetes, again, the primary prevention, I think that really resonates because once you sort of, you could take a substance and be like, I'll feel fine later. But if you don't look at it with the long-term scope of what this is doing to your body, I think that analogy really makes sense. I don't want to bury the fact that, I think Dr. DuPont touched a little bit about it, but I really just want to put it plain out there in the spotlight. One choice prevention takes the position that youth should make no use of all substance together, so alcohol, nicotine, cannabis, any other drugs, before the age of 21, or as you guys were just debating, maybe even 25. But officially, one choice prevention takes the stance of 21. Why does that unified standard matter clinically and behaviorally?
So, yeah, thank you so much. It really matters a tremendous amount because it's a health standard. So when we have a health standard, the reason we have it and the reason we feel confident about it is because it's backed by science and data and experience. And so it's like that seatbelt I mentioned. If I tell someone wear your seatbelt, they know it's not just like I have a thing about seatbelts. It's because that's really the data is very strong for seatbelt wearing. And it's not just in the front seat and it's not just at night, or it's not just if you're the passenger. Everybody should have a seatbelt on every time. And then we have the data to back it up. And that's the way a health standard is. It needs to be very clear and it needs to be universal. And that's the way the non-use message is for health. It's universal. So the non-use for health message is universal across that spectrum. So if you have a young person who's never used, that's the right health message. But if you have one that is using but not having any trouble, it's still the health standard is non-use. If you have one that has a diagnosed substance use disorder as a young person, the health standard hasn't changed. And it doesn't have any kind of morality or purity test or, good kids, bad kids kind of thing. It's just what the science and data supports. The two things that are really important to me to understand about this, one is that science of the developing brain, which we have already talked about. And I love 25. I always worried about college students and that early adulthood age too. So that developing brain is really, really important. Things that happen to our brain, and especially these things that hijack, again, that dopamine pleasure center of the brain, retrain or literally change the trajectory of that brain for that person. And so it's very important to not expose the brain to those things during those years of development. But the other reason that we have this concept of one choice is what we say is because we did this research that showed that for youth, all substance use is connected. So when they make the choice to use one substance, for example, marijuana, their risk of using other substances, nicotine, alcohol, pills, any other substance, goes way up. And so we did this study, what I call little bars, big bars, which shows if you would look at teens and say to them, did you use marijuana over the past month? You have one side of the graph has little bars, which is associated with they were very unlikely to use other substances if they said no. They said no marijuana in the past month, little bars, unlikely to use other substances. If they said yes to past month marijuana use, big bars, much more likely to be using other substances. And that's the case with whatever drug you look at it. Look at alcohol, look at nicotine as your primary drug you're comparing. When a teen has made that choice, maybe I will try vaping, for example, it becomes a really slippery slope of, well, if I'm vaping nicotine, maybe I'll vape cannabis. Or if I'm vaping, maybe I'll start smoking a cigarette. Or if I'm vaping, maybe I'll drink some alcohol. It becomes a question of which substances, when to use it, with whom do you use it? So many questions. But if that person makes that initial decision, no thanks, not for me, to whatever that first thing that they were introduced to, then they're very unlikely to use other substances. So we see that it kind of boils down to that one choice that that person is making. Am I someone who uses substances or someone who doesn't use substances? sounds really easy, but I always talk about this as being an active and continuing choice. Being a teenager is hard. So you can't just say to your kid, don't use. I mean, you can, and that you should, and that's great, but it has to have many more aspects to a conversation than this because it is hard to navigate those social situations. And you aren't going to be there with your kid, especially all the way till they're 25. So they need to have the data, the science, and understand the health message of non use.
Hmm. Thank you so much for sharing a little bit more about, why that matters. I love talking about, the level of risk that increases because it is so important. And I think that your organization's mission is a really great one, and the science really backs it. We've talked really high level about what the science says, what the strategy says, but one of the persistent challenges in getting people help is that the formal healthcare system often isn't where people turn first. They often turn to people and institutions they already trust, whether it's a faith community, a school counselor, a neighbor, or community organization. So, how do we build real bridges between those trusted networks and the providers and public health systems that can actually connect people to treatment and prevention resources? And where are those bridges missing right now?
So yeah, I'll start with our strategy. When our director Carter, she built an amazing team, and she gave me the task of writing the first outline of the strategy, and she wanted it different and bold. So I was thinking about that all the time, and I was there in synagogue, thinking about the strategy, and then I realized, hey, the answer is right in front of me, right in front of me, and the next day or Monday. I came in and wrote in God and faith into the strategy and put it in the front of the strategy and put it in scientific terms that 83% of the population believes in God or a higher power. And that is a powerful tool. It's a tool to be used, not to be hidden. And we have outcome measures, for substance use disorder and probably for other medical problems of better outcomes for people who use this tool. And really proud that it was not edited out. You could say, imagine, that the strategy goes through lots of vetting and lawyers and, separation for church and state. They'd want to, advise us to get that out. And really thanks to President Trump, who's made faith a huge focus of the administration. I said, okay, I dare anybody to edit God out of the strategy. Now, your question is how do we make those bridges? We've had lots of discussions on the integration of faith and medicine, and we do that routinely at end-of-life care, right? We're very acknowledged about that, and we want to bring that into the mainstream. We now have faith leaders at every department of government, including our own here at ONDCP, and we are working ways. And we don't have the solution yet, but because just like you said, Melissa, sometimes people come to their faith leaders before they go to their doctor. So that means we need to educate the faith leaders to recognize some red flags when it comes to potentially addiction. People, maybe it'd be like, oh, my son doesn't want to go to school or their grades are dropping, but maybe we need to dig deeper and see if that is, besides a mental health problem, a substance use disorder problem, and teach the faith leaders how to get resource, how to intervene. And so we need to build that structure for all faith communities. And we also, we just recently had a summit on best practices for treatment in homelessness addiction. And a common denominator in best success rates are the rescue missions, the faith-based programs who bring that in. We don't want to force faith on anybody, and we're there for you, whether you have faith or not. I mean, as an emergency physician, I can tell that. But if you have this secret sauce, you need to unleash it. You need to use it. And we found that a common denominator for the best successful programs for recovery are the ones who use faith. And we want to continue to encourage that and foster that.
Yeah. And Dr. DuPont, from a prevention standpoint, we know that trusted messengers matter enormously. But, that messenger has to be able to reach everyone. How do you think about building those community bridges in a way that's inclusive and doesn't inadvertently create barriers for people who most need to hear that prevention messaging?
Yeah, I think this is really important. The thing is, I always think about who is responsible for prevention messaging. And I've given a lot of talks on prevention to a lot of different audiences. And some are really obvious. They're coalition leaders that that's their bread and butter. That's what they do all day long. They're the experts. I learn from them all the time. It's wonderful. But it turns out that everybody has a role in prevention. And so I think about, I can give a talk to literally any audience and explain to them why they have a role in prevention. And it has to do with being educated and knowing what the resources are and where to find them and how to connect people with them. And really being grounded in the science and data and being open-minded and non-judgmental. These are all the components of being available to the young people in your life. So if you have young people in your life professionally, you're a doctor, a lawyer, an educator, a faith leader, whatever it is that your role is, that you have in interactions with youth or with families, you should have a role in prevention. And I want to make sure that you have the information that you need to help people understand all of these topics that we're talking about why the non-use norm is brain protection, and also about if you've got someone who's struggling, how do you get them help and where is help available? And you want to use whatever tools you have available. So I want everybody at the table. That's my point. I want everybody at the table, but you do have to make sure that you're giving the right message to the right person. So if you're giving a general no use message and you've got a parent in there who's got a kid that's really struggling with advanced substance use, it's not going to be a very effective message because you're going to miss that mark of what that person needs to hear and what they need to understand.
That's a different cohort, right?
Exactly. Totally different cohort. Exactly. And so, but a lot of times when you're speaking or whatever, or you're teaching or you're whatever, caring for people, you might not know initially what cohort that someone is part of and what you need to bring. And so I think it's really important to make sure that we're meeting people where they are, helping them with what they currently need help with, and then also using language that is inclusive and inviting to them. And so if someone is involved with a faith community, that is fantastic. And I am 100% in agreement with what Dr. Lev said, that is a strength of theirs that they can rely on. And I see that all the time in my practice, that people, when the going gets tough, it's really nice to have a faith community if that's part of your life. The thing that I have to recognize also is for a lot of my patients, they may belong in that 80% that believe in a higher power or a spiritual something but it's not a religion. And I have to be very careful to walk that line that doesn't sound like I'm alienating people. So one of the things I've noticed is even like AA sometimes, which has that belief in a higher power, can be alienating to people, even though AA is not at all affiliated with any religion. And so language matters, and we'll talk about that some more. But here's a case of where language matters, that you have to, read the room of who you're speaking to and make sure that when you are giving messages, either of prevention or treatment or recovery, that you're addressing the needs of the person in front of you.
Yeah. I think it also goes back to what we were talking about before about, wanting to make a message right for someone. Everyone comes from a different place. We're maximizing the toolbox, so to speak, to make sure that there are the messages, resources, people, trust there, so that wherever people are, whatever cohort they're in, they can have a seat at the table, as Dr. DuPont also mentioned. Since we are on the topic of language, we know that, stigma remains one of the most stubborn barriers for people who need help to seek help. How does national messaging and the language we use either reinforce or reduce stigma? And what does a culture where recovery is truly normalized actually look like?
So you will not find the word stigma in the strategy. And the reason is we don't want stigma on the human being, the person who has a medical illness and deserves empathy and compassion and the best care possible. But frankly, we do want stigma on the drugs. I don't want you to use fentanyl. I don't want you to use these drugs. There should be. And if you think about it in tobacco use, cigarettes, yeah, those are bad. Cigarettes have been stigmatized. And we found that universally, that message can be mixed. So that's why we have not used the word stigma in the strategy, and instead really emphasize compassion, empathy, treating addiction like any other chronic disease.
Dr. DuPont agrees here that empathy and compassion need to be at the forefront instead of language that emphasizes stigma around substance use. And from the clinical side, she's emphatic about two things too: that addiction is a real illness and that recovery is just as real too.
These illnesses are absolutely as real as any other illnesses. So these are real as cancer, real as diabetes. So we need to treat them as patients with unconditional respect, empathy, and compassion. And so I do think the way we need to do that as a society is by really making sure people understand the complexity of these illnesses and the pathways to recovery. So kind of coming to that second part about kind of what does this mean in terms of recovery, I want to be really clear that recovery is absolutely possible, and it's happening around us all the time, even from people with very, very significant substance use disorders. There is nobody that is too far gone unless they are dead. You can't treat dead as a very, sad way of thinking about things. But otherwise, there is an opportunity for hope and for full recovery, sustained lifelong recovery. And so I think that is really important for us to see. And recovery from substance use disorders is the one disorder where I think the person is actually better than they were before they had the disorder. Because the process of recovery is a process of connecting with community and a process of finding meaning outside of yourself and getting the help you need for other things, mental health concerns or social concerns, housing or family, whatever that is, getting those supports in place. And so recovery is a miracle. It's just fantastic.
Yeah, I love how both of you are taking this with so much, like compassion, empathy, community. They're all so important. And just the way you're talking really resonates. From what I've seen people in my life who have struggled with substance use disorder, who have recovered or on journeys to recovery. And, as we're wrapping up here, I know that both of you, just across this conversation, getting to know you both, you lead through a deeply, deeply human lens. I'm wondering, is there a patient encounter, a family, or a moment from the front lines that still sits with you and still shapes how you think about this crisis today? And what do you most want people listening to this episode to carry with them?
Well, I guess my first patient story started in my community. It was on Yom Kippur. We're all gathered in the synagogue, and one of the young boys was in the ICU, expected to die because of a drug overdose. And I remember, being in the ICU, holding his hand and seeing his family and his dad in particular just broken up and really saying goodbye to his son. And it was pretty gut-wrenching. And then months went by, and Aaron Rubin, he did not die. He became quadriplegic, and his mom, Sherry Rubin, became an activist. And the two of them went, around the country. It was not easy with any, electric wheelchair and everything, in teaching on the dangers of prescription opioids. At that time, it was prescription opiates. And Sherry brought me into the fold. Like, why are the doctors giving all these drugs to our children, and our children are dying from that? And she brought me to meetings like, okay, doctors, why are you guys giving too many drugs to patients? And it's like, this is what I'm told to do. If I don't do that, I'll get in trouble. I mean, we had patients in the emergency room yelling, like, I know my rights. I need to get my pain meds. We were told with the, fifth vital sign, that was what we were taught to do at the beginning of my profession. And I think about it, it's probably why I'm here today. I'm making amends. I am in recovery, my own professional mistakes that we did as collectively. as a profession to fix that. And from there, I went to really study the problem, I teamed up with the medical examiner in our state pharmacy system and looked at every single person who died of a medication. I considered all of those, potential deaths in my hands, in my mind, my profession, and really learned from that. I called those the death diaries because they were like told a story of someone who died from prescriptions right before they died. And I applied that to my living patients. When I saw them, it's like, oh my God, your medication record looks like someone I just saw from the morgue. And from that, I learned to always listen to the parents. They've been my moral compass. We wrote guidelines in San Diego 5 years before the CDC ever wrote pain opioid guidelines. And it's because of my experience with those patients. And then I met the patients, the parents whose children died of fentanyl. That was COVID. We were all about COVID, and I was fentanyl. Listening to the parents, and now there's a group of parents, children have passed away and died because of marijuana, and they're growing in their grief, and so listening to those parents, they're ahead of the curve of what government is seeing and what data is telling us, and they've been my moral compass. And to this day, in our office, if you look at my office and look at our TV screens outside, we have faces and pictures of people who died from overdoses that remind me and the whole staff here at ONDCP of why we're here and why we're doing what we're doing.
Yeah. So I feel a little bit the same, that it is the pictures of loss that stick with me first. And so one of the things I often think about is how, I told you how substance use among teenagers has changed, and there's this growing number of substance-free teenagers. But the adults sometimes are like, oh, well, but I used when I was in high school and I was fine. And they want to normalize and kind of fondly remember their antics as teenagers. And I look at them and I'm like, I'm really glad you're okay. I'm thrilled that you're okay. But was everybody okay? If you think about your high school class, your college class, that young adulthood, was everybody all right? And the answer is, of course, no. Everybody knows someone. At this point, all of us have been touched by tragedies from substance use, a whole range of things. It could be an MVA, or it could be a fentanyl overdose, or it could be a mental health crisis. So it's those stories, those faces in my own life that often are kind of my why, my motivation to kind of stay in this and keep fighting, because I want not other people to not have to go through that. But one of the things that's interesting is that motivates me as a physician and as a prevention person, but it actually isn't very motivating for young people. They don't actually see risk the same way. And so that now what I find extremely motivating, because I see how much it motivates them, is the stories of young people who have made that choice not to use. And so if we can put the microphone in the hands of the young people who have made the choice through high school, through college, not to use, and for them to explain their reasons why, very deeply personal reasons why they've made that active choice not to use, that turns out to be extremely motivating to young people. And so when I think about stories now, I'm more likely to think about those young people and be like, oh yeah, those are my heroes, and I want to make sure that I keep getting them in front of those young audiences.
I will say, when I was in college, some of my favorite people were the folks who didn't use, they didn't go out drinking, partying. They found so many other fun ways to fill their cup, so to speak. So I really love that sentiment, and it's a really positive way to sort of wrap up this conversation. Doctors Lev, DuPont, this conversation has been so enlightening and so important for getting to understand where we are in this substance use landscape and how we can promote better prevention and policy and humanity, as you both really showed in this space. So I wanted to thank you both for the work you do and for sharing it with us today.
Thank you so much.
Thank you. And Carolyn, thank you, because I always, every time we get together, and it doesn't matter where, whether it's for lunch or on a podcast, I always learn something. And Melissa, this has been a great experience. Thank you.
Thank you so much for the work you're doing.
Across this conversation, I'm reminded that prevention is powerful. It's about possibility. It's about protecting a young brain long enough for someone to become who they're meant to be. Dr. Lev keeps the faces of those we've lost to overdose on the screens in her office so no one on her team forgets why the work matters. And Dr. DuPont reminds us that the most powerful voices in prevention might not be from doctors or officials after all. They are the voices of young people who quietly chose not to use, and who are, in her words, the real heroes of the story. My deepest thanks to these amazing women for their time, candor, and compassion they bring to this work every single day. Read the National Drug Control Policy and check out the Institute for Behavior and Health and One Choice Prevention in the show notes. If you enjoyed today's episode, share it with someone who needs to hear it. And if you're on a journey with substance use, know that recovery is real, and it's happening all around us. Thank you for joining me on Empathy Affect, and I hope you'll tag along next month. Thanks, y'all.
Empathy Effect is a product of Forrest Marsh. You can reach us at forrestmarshmedia@forrestmarsh.com with any feedback, questions, or inquiries. If you want to know more about today's guest, are interested in participating with Forrest Marsh, or becoming part of our community, check out our show notes for more information.